Welcome, everyone, and thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our guests today, Daniel and Orash, who I'll introduce shortly. I'm Lina Badr, Lead for Workforce Transformation and Development at the International Pharmaceutical Federation, FIP. FIP was founded in 1912 and is the global body representing over 4 million pharmacists, pharmaceutical scientists, and pharmacy workers around the world. Our vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, science, and education. At FIP, I'm also lead for our COVID-19 online program, Responding to the Pandemic Together, through which we deliver webinars, webcasts, and more virtual events where we tackle pharmacy's responses to COVID-19 together, of course. We're pleased to be delivering this event, the sixth one in the Responding to the Pandemic Together series. All events of these series are recorded, and the recordings are freely available to everybody on www.fip.org/coronavirus. In this webcast, we will be chatting to Daniel Cobo from the American Society of Health System Pharmacists to discuss the situation in the US, how pharmacy is responding, and what tools and guidelines have ASHP developed to support the profession. We will also be talking to Orash Dabastani, Senior Pharmacy Director in a New York hospital, to find out more about challenges on the front line. To those listening live, we encourage you to send questions through the questions tab, and we'll do our best to pick those up along the way. It is now my pleasure to introduce our guests today. Joining us from Washington is Daniel Cobo. Daniel is the Vice President of Publishing at the American Society of Health System Pharmacists, ASHP. He's also the Editor-in-Chief of the American Journal of Health System Pharmacy, AJHP. His responsibilities include executive leadership for the AHFS Drug Information Product Suite, which is a ASHP special publishing program, as well as the journal. He received his Bachelor of Science degree in Pharmacy from the University of Pittsburgh in 1987 and his Doctor of Pharmacy degree, magna cum laude, from Duquesne University. Dr. Cobo has authored over 120 peer-reviewed articles, opinion pieces, book chapters, and abstracts. He has served as a toxicology consultant to the World Health Organization International Program on Chemical Safety, the U.S. Department of Health and Human Services Health Resources and Services and Administration Poison Control, as well as the U.S. Department of Transportation and the National Library of Medicine. He has lectured on medication safety and clinical toxicology in Argentina, Colombia, Mexico, and Uruguay. He currently serves as a member of the Board of Visitors for the University of Pittsburgh School of Pharmacy, and he was recognized in June 2012 by the University of Pittsburgh School of Pharmacy as a distinguished alumnus and was a 2013 recipient of the University of Pittsburgh 225th anniversary medallion. Welcome, Daniel.
Good morning, Lena. Thank you so much.
I'm also pleased to welcome Orash Dabastani, joining us live from New York City. Orash is currently the Senior Director of Pharmacy at New York University Langone Health, overseeing pharmacy services. Previously, he was the Associate Director of Pharmacy at Stanford University Hospital and Clinics in Palo Alto, California. Orash has formed and facilitated multiple pharmacy leadership forums in Washington, D.C., New York City, and the San Francisco Bay Area. Orash also currently lectures in NYU School of Dentistry. In 2007, he was named the Virginia Society of Health System Pharmacists Pharmacist of the Year, in addition to becoming a Senior Leadership Fellow of the Advisory Board in Washington, D.C. Orash was named a Fellow of the American Society of Health System Pharmacists in June of 2011. Hi, Orash, welcome.
Thank you. Good day, everyone.
Thank you both for joining us today. Let's start by talking about the situation of COVID-19 in the USA. Dan, this question is for you. In terms of the spread of COVID-19, we're all well aware that the US is the hardest hit country in the world as of now, reporting the highest number of confirmed cases as well as the highest number of deaths. what can you tell us about the latest trends we're seeing in the USA across the country?
Well, Lena, it'll be exciting to answer that question. Let me show my screen so I can share some data from Johns Hopkins, which is one of the primary resources that we use for these data in the United States. I think, first of all, as of today, there are over 1 million cases of COVID-19 that have been reported in the United States, with over 60,000 deaths. If you look, there really are hotspots across the United States, as you can see in this deep violet color, that represent relative numbers of cases and deaths based on population numbers. And you can look in the area that Arash is in on the eastern seaboard of the United States, from Boston all the way down to the New York City area, where there have been large numbers of cases. Hotspots for certainly New York City itself, as Arash will talk about, has been heavily hit. If you look at the top counties in the United States where there has been, where the highest number of cases as well as the highest numbers of death are, 13 of the top 20 counties are in the New York City metropolitan area, including areas north of the city, as well as in New Jersey. So the New York area for sure has been hit extremely hard, as I think everyone is aware of. Also, we've seen in the United States other large metropolitan areas such as Chicago, Philadelphia, Detroit, as well as Miami-Dade in Florida have been hit. Two other comments that I would just make on the situation in the United States in terms of what we've seen. Clearly, long-term care facilities, nursing homes have been hit very hard. We've seen significant outbreaks in those facilities. And we're also seeing now, we are observing really increased rates of exposure, disease, as well as death in communities of color, right outside of Washington in Prince George's County, Maryland. It's been very obvious that communities of color have been hit much harder, as we've seen a higher number of cases in African Americans, as well as a higher death rate. So that's the status as of today in the United States. Arash, I don't know if you wanted to add on to some perspectives from the New York City area.
Yeah, thank you, Dan. Thank you, Lena, for the background. So I'm in Manhattan, right in the middle of the epicenter, and as Dan had alluded to, we were hit hard and we were hit fast. It's pertinent to provide you with some background and some historical perspective. So Friday afternoon, March 13th, we went home fully aware that we had started admitting COVID patients, less than 10, and very, very quickly later on that afternoon, a series of dams broke relative to preparation, drug availability, and one of the main topics, which we'll discuss later, staff availability and staff emotional stress that pursued. We took 3 immediate actions. That Saturday was really a marathon of calls to pharmaceutical manufacturers. Quickly, I personally realized I need to put together a list of every medication that has been discussed as possible therapy for COVID, because there was really no established, approved, and accepted protocol, and contacted every single one of those manufacturers to try to establish at least a line of communication and be able to guarantee some level of supply as our physicians start to ordering that. That the next day on Sunday, the number of emails and questions had gotten to a point where I basically got in my car and came back to the hospital to be able to address the needs of the staff. That was Sunday, the 15th. We held a pharmacy manager call at 7:30 p.m. that night, just to make sure we touch base with all the managers. We have a plan. We had anticipated, because the schools were announced to be closed, we had anticipated a high number of staff calling out because no one was really prepared or had prepared a plan to manage their home side of the pandemic and the home side urgencies. Fortunately, we didn't have that, but that was Sunday, March 15th, and the events of the following 6 weeks were almost like a dream.
Thank you for that, Arash. And in your opinion, what makes areas or states like New York the hardest hit? What factors have played into that?
Clearly, the population density has something to do with it. There was a published study that the sort of explosion of COVID was most likely initiated in the subway systems. We are the busiest and the most populated metropolitan area in the country, with a population of around 15 million, heavily relying on public transportation, very close contact. The idea of social distancing prior to COVID was something that was beyond belief. We're also a hub for international travel, both for tourism and also for connections. And also business. Well, New York is a business hub with Wall Street. For anyone who's been in and around Wall Street on a weekday, you will not be able to get farther than 2 inches from the next person. I mean, it's a very busy, heavy area. And you factor in the unknown. Back in January and February and early March, the general public did not really have a clear idea of exactly how the virus was transmitted, what to do, what not to do. Really, the only advice was hand washing. I would say you could walk around Manhattan on March 7th or March 8th, and you would find less than 1% of the population with even masks on.
Dan, would you like to add to that from a national perspective on factors that have made some areas worse than others?
I think that Arash has really hit on all of the major points. I would just emphasize again, it's certainly population density, the evolution of the use of preventive measures, and how we saw that anywhere from January through today, how we've seen that evolution. And in the early days, if there really was not the great use of preventive measures. And as well, I would just add, along with population density, Arash pointed to international travel, but even across the United States, areas that are travel spots. So if you look at that Johns Hopkins map, there are some areas, for example, in Colorado, ski resorts, where there were outbreaks of cases because of the density of people who were traveling. So both national and international travel are certainly additional risk factors.
That's great, thank you. If we delve a little bit deeper on effects in the health system, and particularly on frontline health workers, I'd like to ask both of you, what have been the effects so far on frontline health workers across the board, be it pharmacy or otherwise, on their physical health, on their safety, but also their mental health? Maybe I'll ask Dan and then go back to Arash.
Well, first I would start just with the complexity of the disease and the fact that we've seen it evolve. I mean, the health professionals originally were getting information that this was a relatively simple upper respiratory disease, and we really did not understand, I don't believe, the true complexity of it. And as we've seen it evolve into a disease that has effects on thrombosis. We're seeing stroke in young people. Things, the types, the degree of ARDS that's being observed in patients in the ICU setting. It's really profound, the complexity of the disease itself. I think just none of us has, for the most part, we've seen other pandemics, but none of us in our careers or our lifetimes have been confronted with anything like this, and that in and of itself is overwhelming. The demand for treatments, and Arash has already alluded to some of the supply chain issues, but number one, we up until some news yesterday, we have not had great evidence about effective treatments, and there have certainly been, as we've when there have been inferences about drugs, for example, that might be effective, there's been an increased demand for those. The demand that frontline health professionals are confronting for both supplies and equipment and medications has been overwhelming as well. And then at a more personal level, frontline health professionals, their own health is a great risk. They have to ensure that they can protect themselves. There have been some real challenges in some situations related to personal protective equipment. I think that translates into, you have people who are working on the front lines who are very concerned about the fact that they may be going home and exposing their own families after they've worked their shift. And then the psychological impact of the sheer stress of the response, but also some of the horrific things that frontline health workers are seeing. We're extremely concerned about stress and anxiety and post-traumatic stress disorder. Had a horrific situation earlier this week where we saw an emergency physician from the New York City area who committed suicide. So this is an extremely profound experience for all health workers, including pharmacists who are on the front lines.
That is very tragic. Arash, from your point of view on the front line, what has been the impact on your team?
I would certainly echo Dan's comments from a universal perspective, more locally to what we had to deal with. We have a system-wide pharmacy department of around 350 individual employees. I'm at the flagship hospital. My office is here in the flagship hospital. Really, Lena, the fear of the unknown. There were an information overload coming in from all different angles. The media, fortunately, our institution started having a concise daily communication around COVID. And I want to read you a couple sentences of an email I sent out on Saturday, March 14th, because for the first, I'd say 3 to 5 days, the anxiety showcased by staff was clearly our number one issue to deal with. It was a bigger event to manage than drug shortages, supplies, protocols, because if you don't have your staff fully engaged and available, both physically and mentally, then you couldn't do all the other things that pharmacy is known for. But here's a piece of an email that I had to send to staff, which is, it states, invalid information from questionable sources or no sources at all has the potential to create confusion and chaos. It is critical that we focus on the daily concise communication provided by our institution. It was something that we absolutely had to emphasize. To staff's defense, there were the school closures, concerns about themselves getting sick, their families being sick, their coworkers being sick. Is the institution, this was arguably the largest question, is the institution appropriately protecting me? Should I be going anywhere near COVID patients? Should I be in the elevator with frontline staff? Are we wiping down drugs? So again, it was really the fear of the unknown. At that time, the New England Journal letter about the 3 days of virus living on surfaces, etc., hadn't come out, so we really didn't have any information. But again, lack of information from one end, lack of real scientific information on one end, and an overload of vague information on the other really contributed to that.
Thank you for sharing that, Arash. There's so much that resonates with a lot of what other pharmacists around the world have said. So in a way, this pandemic has brought us together in terms of shared challenges and issues. And yesterday we had another webcast where one of the pharmacists from Spain did contract the virus as a community pharmacist. So the absolute fears are very, very real. I do have a question actually coming in from a colleague from Nigeria, Mohammed, and I think really asking and wondering, perhaps this is for Arash because it is more concerned with practices. What is the specific role of pharmacists or what has it been in the management of patients that were confirmed to have COVID-19? How does it work?
That's a great question, and I'm glad it was brought up earlier on. That just demonstrates the importance of it. It's twofold, and I'm not going to talk about the distribution aspect. We'll discuss that down further. It's really twofold. As Dan clearly alluded to, there was no established protocol, we didn't have any clinical trials. There's really no guidance from external sources. So on one hand, the role of the clinical pharmacy was to really rummage through all the available letters, discussions, any resource, any publications that were coming out on nearly daily basis, and try to make an informed clinical decision and educate the medical team about that. Now, the second part of, very important role of clinical pharmacy was, you have to remember, the majority of these really sick COVID patients also had underlying conditions. Most of them had chronic issues that also needed to be managed simultaneously while you're loading additional sort of quote unquote trial drugs for COVID. And that's really where the importance of pharmacy was being emphasized, because no one really had the expertise of what happens if you're managing a diabetic heart failure patient with 14 drugs, and now you're adding a load of antivirals and other modalities to, and what are the interactions, what's the best time, are they qualified, QT prolongation with a lot of these medications. Who better than to be the sort of guiding light at this point than clinical pharmacists?
That's a great answer to a great question. Thank you, Arash. And I guess this ties in nicely with the next issue, which is talking about the profession as a whole. So more of a professional point of view, starting with you, Arash, then over to Dan. What do how do you see what's happening affecting the profession? What's facing pharmacy in the US at the moment?
Well, for one thing, we're back to basics. We've hit a stride, although a sort of a new norm stride, if you will, in at least having some level of normalcy around managing the COVID patients, because that's the majority of our load right now. I say back to basics because we have to get the basics right. We have to procure medications, prepare medications, distribute them appropriately. Picture this large pharmacy machine that has to produce 24/7, 7 days a week for a large number of sick, very sick, critically ill patients on ventilators. There is no room for error. There's no room for slowness and lax, because medications have to be prepared at a very, very high rate and be distributed appropriately in a timely fashion to patients, which is really the basics of all pharmacy, aside from the clinical aspects that we talked about. So that's one thing. The other one is we can't lose sight, and we have to continue to stay laser focused on what's coming out. Dan alluded to this, and we'll talk about this later on, about the new modalities that are now being touted for and recommended for treating COVID. So again, it's a twofold change, that collaboration of clinical pharmacy with operations, and the minute a new drug is publicized for COVID, you could certainly and inherently count on it being on shortage and allocation. So then the communication between the clinical folks who are getting that information to the operations to prepare it, to the procurement, to to be able to procure that drug is absolutely paramount for appropriate pharmacy operations.
Thank you for that, Arash. And Dan, from the perspective of the American Society of Health System Pharmacists, what is the profession dealing with now?
Well, I would take a step back, even as you and Arash and the audience knows, ASHP primarily represents pharmacists who work in the hospital and the health system setting across the continuum of the health system, from ambulatory care through acute care and even long-term care settings. But taking a step back further, I think that what we've come to realize, and I don't think only in the United States, I think probably around the world, is that pharmacists are playing a critical role as frontline providers across the continuum. So our colleagues in the community setting are being confronted with people who may actually have been exposed, individuals who are concerned about their exposure, and then across the continuum, if it's a pharmacist in the emergency department or the ICU, we're seeing extensive pharmacist engagement. And as Arash was talking about, I think that evaluation of evidence and suggested treatment modalities, the speed at which suggested treatment modalities have been put out there has been just incredible. And so trying to understand the evidence around the effectiveness of these modalities, and also to ensure that we're not doing anything that is unsafe. So I think the example of hydroxychloroquine is an excellent one, where we have a medication that was that there were statements made about its effectiveness, and yet that wasn't truly proven, and there wasn't good evidence around that, and a drug that has some pretty serious toxicities associated with it in terms of QT prolongation, as Arash mentioned. I think that pharmacists also, we're seeing a redeployment. So given the nature of these cases and the individuals who are becoming so sick, we see an increased demand for pharmacists in the ICU setting. And we're also seeing, though, even moving away from COVID-19, pharmacy practice having to sort of take different approaches. So we're seeing increases in the use of telehealth, for example, and telepharmacy in the United States. So across the spectrum, in terms of the care of individuals with COVID-19 and ensuring that they have safe and effective evidence-based care, as well as continued pharmacy care for our patients, we're really seeing a need to modulate the way we do things, maybe take new approaches, test innovations in real time.
And Dan, if we look at it a bit deeper on a subnational level, how has pharmacy's response and the impact on pharmacy differs between states? And we've spoken already about how different states have been hit in different ways, but what's the link between this and pharmacy?
Well, I think that really the approach that, and I'll focus on hospital and health system pharmacy departments in the United States. I think that the overall approach is going to be pretty similar. There may be, some differences, some regional differences, maybe institutional differences in the way certain things may be approached. But overall, there's going to be, as Arash mentioned, that focus, starting with procurement of the necessary medications, then ensuring provision of those to the patient at the bedside in the acute care hospital, for example, the provision of clinical pharmacy services. All of those approaches are, I think it's fair to say, going to be relatively consistent across the United States. One of the things, though, that we're clearly seeing is that there's varying demand. Going back to the map that I showed previously, you can see where the hotspots are, and certainly there are going to be greater demands for pharmacy services in those areas. But across the country, departments of pharmacy have been preparing, and that includes some of the things I mentioned before, such as going to telepharmacy models to provide care for their patients. So even in places that maybe have not seen a significant number of cases, they've had to modify the way they're offering care, because their organizations, their hospitals need to be prepared if there is a big influx of patients.
I think you've touched upon really important issues to do with capacity. Arash, what are your views on this?
I agree with Dan relative to the rest of the country. Again, more local to us. Interestingly enough, there are some advantages in being a very large metropolitan area. For instance, we never even came close to having a pharmacist shortage. This is, again, a very large metropolitan area with 3 local schools of pharmacy, many ambulatory care and outpatient facilities that were closed, leaving a high number of pharmacists and other pharmacy personnel available as resources, which we clearly tapped into. So although we were hit hard and fast, but on the sort of silver lining positive side, we did have access to a tremendous amount of pharmacy resources.
You know, Lena, I would just add on to one thing that, and again, I think that it really relates to something that Arash said, that the places that were affected early on, and especially New York City, in many ways they've served as laboratories. And across the country, other pharmacists and departments of pharmacy, and certainly for us at ASHP, we've learned a great deal from that experience in New York. And I would point to something that I'm not sure that we completely appreciated, and Arash, you're in a better position to address this than I am, but the need for drugs in the critical care setting. We heard a lot about shortages of ventilators a bit earlier in the pandemic response, and there wasn't as much focus on the drugs that are required to care for patients who are being artificially ventilated. And what pharmacists across the United States have now learned from the New York City experience is very informative as they plan if there are subsequent waves of this pandemic.
And Dan, maybe to you, talking about the effects or the impact now on how health systems are structured. What about how we all know, most of the listeners know that the US health system is largely privatized. How is that linked to what's happening?
Well, what hospitals across the United States have done to prepare for influxes of patients is that they have really tried to decrease elective admissions, elective procedures, even on the ambulatory side, because I think, again, it's important to take a step back and recognize that there are very few hospitals that only provide inpatient care these days in the United States. What we're really looking at are organized health systems that provide care across the continuum, including a very big ambulatory component. And certainly, you know, for decades now, we've been witnessing the movement of care from the inpatient setting to the outpatient setting, and a lot of interventional care, surgical procedures occurring in the outpatient or ambulatory setting. As all of that elective care has been put on hold, that actually causes a pretty significant financial pressures for hospitals and health systems, because the revenue that comes in from those procedures and surgical procedures isn't coming in, and it really creates some real stresses in the system, because there's a demand for resources on the inpatient side, and yet revenue is not as significant. And you know, we've seen reports of on areas where there have not been surges of patients. We've seen reports of, even furloughs of non-essential employees in hospital and health system settings because of some of this. So the demands are very complex.
Thank you for that, Dan. We are receiving a lot of questions about treatment and diagnostics, and I'll pick those up in a little bit because I think some of them will be answered very soon. But we want to talk about preparedness, and I'll stay with you, Dan, and then take this to Arash. What measures have prepared pharmacies or pharmacists better than others, if that is something we can ask? And what are the learnings from this for strengthening health systems? So back to that health system strengthening and capacity issues. What can you tell us about this?
Well, I think that, first of all, I think it's quite common that departments of pharmacy across the United States in hospitals and health systems take very active approaches to preparing for large-scale emergencies or emergency preparedness. And as departments develop their own plans, which are really critical to this, and if I have a chance later to show some ASHP resources, I'll show a preparedness tool that we've developed specifically for COVID-19. But starting with the departmental plan, ensuring that that's integrated into the institutional plan as well as what's happening in the larger community, because I think that it's one of the things that we've seen very clearly with COVID-19 is that you don't have you're not existing in isolation. There are multiple layers of integration, ensuring that staff are prepared and in terms of their competency to manage the what will result from whatever the emergency is. And I think with COVID-19, and again, I think Arash is in a much better position to talk about this, but that in fact, some of the preparedness has had to occur in real time as you start to understand aspects of a pandemic that we just weren't aware. It's sort of preparing for the unknown, and the fact that you need to begin to very quickly come up to speed on what the specific characteristics of this particular pandemic are. And the last point that I would make that I think is extremely important, and sometimes because of the focus on acute care and the basics, as Arash was mentioning before, I think it's really critically important that departments are prepared to address stress in their employees, the health of their employees, both physical and psychological, and over the long term, look at the risks, the risk for PTSD, because I think that is a real concern that we should be taking very seriously.
Absolutely. Arash, what are your views on this in terms of preparedness? And you can tell us a little bit more about how it really feels on the ground.
Yeah, certainly, and some of it will be a repeat of what Dan just mentioned. We learned rather quickly that a lot of existing units were going to be converted to COVID units, and the COVID units were rapidly being converted to critical care units. So I alluded to this earlier, but the importance of standardization. These are relatively common denominators with the same level of patients requiring relatively the same modality of medications and care. So we quickly develop protocols and standards, or what are we going to stock in these floors? How are we going to restock them? How often are we going to restock them? The coordination of all the pharmacy efforts, I believe it's the third time I've mentioned the importance of coordination between the pharmacy departments, procurement, operations, and clinical services as things are rapidly changing. The importance of constant communication, both internally and externally, internally with staff, externally with vendors, more importantly, societies. We talk about ASHP, keeping them abreast, asking for help and assistance where needed. Some of the key points to preparation. And I think, what do I recommend? be nimble, be flexible. These are, I believe Mark Twain said, it's not the strongest and the most intelligent of the species that survive. It's really the one that's more adaptable to change. And this is truly an environment and a scenario where that really applies to everyone, but in this context, to the profession of pharmacy and pharmacy leadership in general, to keep things simple. Again, there's something I mentioned earlier, which is the importance of basic functionalities.
Absolutely, I think we can agree this might be one of the biggest agility tests for pharmacy, but also all of the health workforce in terms of being responsive. How about different pharmacy practices and sectors? And I know we're getting a view from you, Arash, on hospital, but maybe how has this affected the different sectors differently? Especially we're talking about hospital and community being the front line. Arash, maybe I'll start with you.
That's a great question. Community pharmacies, for us, we're a health system, so we have two retail pharmacies, one specialty pharmacy. These are pharmacies that are specifically designed to serve the public. Generally, in normal times, these pharmacies are basically auto drive. They have very, very standard operating procedures. And usually not many challenges, not a whole lot of changes. Interestingly enough, the community aspect came front and center to the overall management. I made a list, I'll quickly go through it, some of the challenges around community pharmacies. Number one, controlling flow and traffic of the public in and out of the community pharmacy. Do you close the reception area? At the very least, the number of patients and visitors allowed in should be limited and appropriately managed. Installation of shields, very important on both ends. You're protecting your staff, you're also protecting the general public. It's a relatively easy thing to do. We were fortunate to have a nice facilities team that came in and installed shields at the point of service in front of the cash registers. PPEs and disinfectants are on shortage, so it's not just important for the inpatient setting, but you also need an ample supply for your community to wipe down credit cards. And I often mention I haven't once heard anything in the media about cash, right? So we are also cash is something that everybody touches. And is quite dirty. Probably carries a lot of different things along with potential coronavirus. But we were fortunate enough to have installed Apple Pay, for instance, to reduce the number of touches. Arguably, the most important point about community pharmacy, there are still chronically ill patients out there, patients that need their chronic medications. Development of a plan on how to get those medications into those patients' hands using mail service, courier service, again, all to reduce traffic in and out of the hospital, in and out of the pharmacy. Our main pharmacy is located within the lobby of the hospital, which was actually on lockdown. Our hospital went on lockdown, so patients couldn't even get there. So we actually had to do curbside deliveries on, patients drive up, all different from the norm. And then lastly, there are COVID-related drugs that are also used for chronic conditions. Hydroxychloroquine, we talked about that earlier, for rheumatoid arthritis. Either dose inhalers, such as albuterol, which also went on shortage as a result of COVID. How do you prioritize those? How do you stay on top of obtaining adequate supply for your existing patients? I'll leave you with this thought. I mean, one good decision that was made earlier on, and it wasn't local to my hospital, was something that was, statewide and possibly nationwide, was don't refill chronic medications for 90 days. Give them, 14 days or 30 days until further notice, so we can better allocate our supplies.
Thank you for that, Arash. Dan, maybe taking more of a helicopter view on the same issue, what can you tell us about this?
I think that, Arash has really provided a pretty comprehensive view of this, very much from on the ground and as the individual who's responsible for overseeing community pharmacy practices. So there's not a lot that I can add. I think I would just make one additional comment, and that is that also pharmacy staff in the frontline setting are truly exposed to the public in a very uncontrolled environment, and there's been a lot of public frustration for obvious reasons. It's completely understandable, and pharmacy staff have been have received that frustration. One example that Arash already mentioned was, those individuals with a chronic disease such as lupus or rheumatoid arthritis who can't get their hydroxychloroquine because of shortages of the drug. It's frontline pharmacy staff in community settings who may be the ones who are exposed to that. So I just think we shouldn't forget that pharmacists across the continuum playing a critical role here, and are really and the folks on the front lines are experiencing this in very profound ways.
Lena, I would add, thank you, Dan, for that. That reminds me, I would add that we actually lost a friend, a community pharmacist who owned his own community pharmacy, who's a spouse of one of our NYU pharmacists. It's a critical business, and he was open and actually ran out of protective equipment and disinfectants, and unfortunately he passed away to COVID on April 17th.
Thank you, Arash, for sharing that. And it is tragic. And I think we pharmacists are putting their lives at risk. And just maybe an opportune time for me to mention that we would love for everybody who would like to keep some of these heroes' memories alive, really, to send FIP the names of pharmacists who have lost their lives. And we will make sure that we honor these through a memoriam list on our website. So thank you for that, Arash. Maybe we'll talk a little bit about legislative changes, and I think we'll then talk a little bit more specifically about treatment and take some of these questions from the audience as well. We know most of the world has been affected by legislative changes, emergency legislative changes that are affecting practice. What major changes have affected the regulation of pharmacy in the USA? Dan, maybe we can start with you with this one.
Sure, and let me start off by saying that what's really critical, and I think that something like the coronavirus pandemic has demonstrated the real value of pharmacy professional societies. We know the value, but it just takes it to the next level. And one of the things that's imperative if a society is going to be effective in an advocacy agenda to advance care and medication use is that we understand the needs of our members. It's critical for us to understand what our members are confronting on the front lines of care so that we can translate that into what needs to be advocated for with regulators, with legislators, across both at the state and the federal level. And what's happened in the environment of COVID-19 is that there have been a number of necessary things we've heard from ASHP members like Arash. So looking at needs as we look at how you ensure that there's an adequate drug supply and that the drugs can get to the patients, advocating for and successfully advocating for with the Food and Drug Administration here in the United States in terms of flexibility in the compounding of parenteral medications, sterile products that are administered parenterally. The allocation and the production of controlled substances. I know that this is an issue that Arash and I have talked about that he sees as one of the most important, but the agreement by the Drug Enforcement Agency in the United States for a 15% increase in aggregate production advocating to focus on the availability of critical care drugs and to assure that those are available, even if including release from the Strategic National Stockpile is another. And I'll give you another example that certainly at the state level was very important when we saw a lot of the media around hydroxychloroquine and its use. We started to observe some really bad behaviors with people hoarding it, prescriptions being written for providers and their family members, which was really stressing, had the potential to stress the drug supply. And ASHP, in collaboration with other pharmacy organizations, put out a statement related to the stewardship of hydroxychloroquine. And we started to see at the state level from state boards of pharmacy very clear guidance on what pharmacists' roles were in ensuring the stewardship of drugs such as hydroxychloroquine. So I think it's incredibly important that a society is engaged with its members on what the most important issues are, and then you have to move very quickly, very nimbly in such a fast-moving environment such as COVID-19 to be effective. These aren't legislative or regulatory changes that can wait months and years. They've got to happen in a matter of days.
Extraordinary circumstances. Arash, how about how these regulatory changes, if any, have affected your practice?
One critical point to note is, unlike many other countries who most likely have listeners tuned in, the U.S. Drug supply chain has many middlemen, if you will. The note about COVID is that it seriously exposed some of the flaws in our supply chain and drug distribution system. And I'm actually working directly with Dan's team and some of his other ASHP fellows to bring this to light, to discuss exactly the importance of the flexibility in the drug supply chain, forecasting, and more importantly, something that we're going to be hearing about and talking about quite a lot, because I don't think this drug shortage issue is going away anytime soon for various reasons, due to issues with APIs out of China, manufacturing shortages in India due to the restrictions, etc. Is the concept of a dynamic allocation. It's something that we haven't really done a great job at in the U.S. So we have a limited supply of a particular medication, but there's no appropriate and dynamic way to allocate it. For instance, similar to supplies such as ventilators, where you get one ventilator from the government for every ICU bed you have, perhaps. We don't have such a process, established process for drug supply chain. So with the help of associations such as ASHP, really advocating for the profession and advocating for patients, working directly with the decision makers such as the DEA, the FDA, even FEMA, we're hoping to improve on that process for future pandemics and future urgencies.
Thank you for that, Arash, because I just want to recognize a question from one in the audience. Kennedy from Uganda has just literally asked about the issue of how are we dealing with the risk of shortages, especially of essential medicines and health supplies, other than those for COVID-19. And I think you've just answered that. I just wanted to recognize that question from Kennedy. Thank you for that, Kennedy.
I'd like to add one other piece of information, which perhaps I may have mentioned or should have mentioned earlier, relative to the role of clinical pharmacy. It is absolutely critical for the pharmacy team in each institution to develop a protocol for not COVID, but the COVID supportive meds, the critical care meds, the sedation meds, the neuromuscular blockers, to really have an option A, which is your go-to drug, but also an option B and C. Because inherently what happens is when one drug goes on shortage, subsequently the other drugs go on shortage. So you have to be prepared to go from drug A to C, back to B, back to C, depending on whatever supply you get in that morning.
I think that's great. That's another nudge for me to actually bring up a question from the audience, if you both don't mind. This is Mohammed from Bangladesh. He's asking, with the use of experimental therapies for the management of COVID, was active pharmacovigilance introduced? And if so, how was the increased reporting on any adverse events managed? Maybe Arash, you can provide some insight into this.
I don't have anything specific to mention on this particular question, other than our clinical team had, at the very least, once daily huddles at the end of the day to discuss anything that they anecdotally discovered. There's what's public and available within the literature, but there's also the daily anecdotal information that we're gaining, because we're in uncharted territories with this. So really, my best answer is constant communication, making sure that the whole team is on the same page with what they're seeing, what they're experiencing, and what they're hearing.
Dan, would you like to add anything to that question?
Sure. I think, the Centers for Disease Control and Prevention here has focused on trying to promote the use of our primary mechanism, which is MedWatch, to report things that are observed. I think that as we've seen the use of drugs off-label or in experimental settings, clearly where there has been probably a more systematic approach to monitoring and reporting adverse events is in those situations where there have been actual clinical trials. And the real likelihood is that, like in so many other situations, what we're going to see is increased information come out retrospectively through what, not necessarily post-marketing surveillance, but what I would describe as post-use surveillance here and over time.
And I would go on to mention that I had made notes for this, and I failed to mention earlier, a very, very large aspect of the overall management of the pandemic has been the very, very large number of clinical trials that were initiated quite rapidly, all around drugs, which meant that pharmacy was front and center in coordination, preparation, procurement of these medications. And some of them go back to that distribution challenge that I mentioned early in the community pharmacy, what these drugs have to get in the patient's hands. And not all the clinical trials were for inpatient, some of them for ambulatory patients.
Thank you both for that. I have another question here that perhaps flows from the legislative changes questions, but also steps into diagnostic testing. This is from Gonzalo from Spain. The US has been one of the first countries not only to approve rapid diagnostic tests for use in the community by the FDA, but also to authorize their use as point-of-care tests by community pharmacists. This is at odds with the recommendations of the WHO, which considers that current evidence does not support the widespread use of these tests in the community. What are your views on the issue? Would you like to take that, Dan?
Well, I'll start, and then I think that first of all, we recognize that testing is really one of the most critical components of this, and in fact, there probably has not been adequate testing, and that's made this even more complicated. Also, I think that it's also fair to say, to go back to my comment previously, that this is a situation where clearly the health policy makers as well as providers need to adapt. We're learning as this pandemic evolves, and we need to be adaptable. We need to be nimble. There is a role if we're going to look at expanded testing. If pharmacists and pharmacies it would make sense to look at pharmacists and pharmacies as potential environments for expanding testing. This really is a very complex issue, and I think it's also fair to say that there has been some divergence at times across the continuum of care that's been provided between what's happened on the ground in all cases and WHO recommendations, for example.
Mm-hmm. Absolutely, and I think that's resonates with a lot of other countries as well. Arash, would you like to add to that?
Just a subjective comment for me. So from my perspective, regardless of the recommendations for or against the point of care testing or testing period, the rather rapid deployment of testing here in my institution, and also the further rapid opening of testing for employees was really one of the most critical positive turning points of the overall management of this COVID, because of the angst that we mentioned earlier. So having the capability to test staff who were concerned, exposed, had been exposed, may have been exposed in the community, and be able to manage them appropriately if in fact they turned positive, was absolutely critical to our overall management, both physical and psychological and operationally of the entire pandemic.
Well, a question for me now. At this point in time, we've just heard some news about the effectiveness of remdesivir, a drug developed by Gilead Sciences on treating COVID-19. What can you tell us about what's going on at the moment? Dan?
Sure, that news that came out, that's news that came out yesterday from the National Institutes of Allergies and Infectious Diseases here in the United States about a trial that was labeled the Adaptive COVID-19 Treatment Trial that compared remdesivir to a placebo. People got 20 milligrams IV on the first day of remdesivir, and then 100 milligrams IV daily for 10 days. It was a randomized trial, as I said, that compared with placebo, and the preliminary findings that were reported from the National Institutes of Health yesterday, and these are preliminary, and we've not seen a complete report on the findings, but were that there was a 31% faster time to recovery for the remdesivir group, so an 11-day recovery in those who received remdesivir compared to a 15-day recovery in those who received placebo. There was no statistical significance in the mortality rates, although the numbers looked like it trended toward significance. In the remdesivir group, the mortality rate was 8%, whereas in the placebo group, the mortality rate was 11.6%. So we're waiting to hear more from the NIAID in today, and I would imagine over the next several days, and certainly preparing, ASHP as an organization is preparing to best support our members, as clearly I think it's as they provide care for their patients, clear that there will be a real demand for this drug.
Thank you for that, and I think the whole world will be on the lookout on how this develops. I would like to talk now a little bit about, in the last part of our conversation today, about the society, the American Society of Health System Pharmacists. We have you, Dan, as an executive from society, but also Arash, a member of it. Dan, can you tell us about what the role of ASHP is, and how is it supporting the profession during these times?
Sure. And as I've mentioned before, ASHP is a professional society that is composed of pharmacists who practice in hospitals and health systems, pharmacists, pharmacy technicians, pharmacy students, residents who practice in hospitals and health systems. We have over 55,000 members. At a time such as the COVID-19 pandemic, what is most important is that the society has a clear understanding of what the needs of its members are on the front lines so that we can react proactively. And I don't know if I have the ability to share my screen or not. If I do, I would be glad to show some of what ASHP has done.
Yes.
There we go. So I'm going to just go to ASHP's COVID-19 Resource Center that really demonstrates much of what ASHP has done to support its members. We have developed an evidence table that is regularly updated that looks at the evidence around the various treatments for COVID-19 as one example of the what we've done to support our members. But if you look across the top of this resource center, we have addressed really across the spectrum what the leadership issues are in supporting members in terms of planning and readiness, surveillance, regulatory issues, looking at the pharmacy workforce, helping with skill development, such as the opening of our critical care certification program to pharmacists across the world who have to care for people with COVID-19 in the critical care environment. On the patient care side, opening our drug information resources to our members and the general public to get more information. Policy side, I've addressed already a number of the things that ASHP has been doing to advocate for our members and with our members based on their needs from the front lines. And then finally, another area that we've addressed is infection prevention. So across the board, what really is most important is that professional societies listen to their members, understand what the needs are on the front lines, and provide resources in a very nimble, very quick way to ensure that we're supporting our members as they work to provide the very best care for their patients.
Thank you, Dan. And perhaps I'll just ask you to maybe tell us a little bit more about the educational resources available, training programs available. What's available at the moment, and how much of it can be accessed from pharmacists around the world?
So as I've mentioned, for example, ASHP has done a number of things on this front. We have an entire e-learning catalog that is available online for pharmacists to access. I mentioned the critical care course, which is a certification resource that ASHP has developed for pharmacists to prepare to provide care in the critical care setting. We've opened this up for use for free so that as the pharmacy workforce needs to really expand into the critical care setting beyond what may typically be provided there, that this resource can be used by pharmacists to very quickly develop their skills. But also with our competency assessment tools, we've provided information on infection control, for example, and emergency preparedness. And ASHP is providing on a daily basis, practically, podcasts and webinars to address what the most current topics are in COVID-19, both in the clinical care of individuals with COVID-19, as well as supply chain and leadership issues. So across the board, we've tried to provide a wide variety of free educational resources to address the needs not only of our members, but also of pharmacists across the world who are confronted with the COVID-19 pandemic.
Thank you, Daniel, for that tour. Really, really helpful to see the excellent resource center that ASHP have developed. Arash, turning towards you as a member of the society, how has ASHP been beneficial for you?
Well, Lena, we're all in this together. We're all stakeholders. The efforts, advocacy, support of ASHP has been genuine and unconditional. I'm only one individual in a sea of healthcare providers, specifically pharmacists in this case, and I have spent no less than 6 or 7 solid hours with ASHP leadership on calls and meetings on weekends, actually, just to point out the genuine and unconditional effort on the ASHP side, and after hours, really to try to rapidly really assist the members and assist the society and assist the pharmacists for what is our common goal and ultimate goal, which is caring for patients. And it hasn't been political, which is really quite nice to see from our society.
Absolutely. Back to you, Dan. Maybe one final question before we come towards the end is about your role as the editor-in-chief of the Society's official journal, the American Journal of Health System Pharmacy. What has been the journal's response so far? And really, what can you tell us about publishing during a pandemic?
Sure. Well, first of all, it really is publishing and the journal play a critical role in the overall response during, and certainly it will after, as well as we look at lessons learned. We have, as a journal, we've seen an increase in the number of submissions around COVID-19. For me, I am so impressed with individuals on the front lines who are so busy with patient care and just all of the effect of a pandemic on their lives, that they still are able to find time to write a manuscript and submit it to a journal. It's just incredible to see that happening. We've seen a large number of submissions related to COVID-19. As a journal, what we are working to do is to provide rapid peer review of those manuscripts so that the authors can get a decision very quickly and can revise their manuscripts very quickly if it's a manuscript that we're going to accept. And we're also working with our publisher, Oxford University Press, to rapidly publish those. So we are seeing across the board letters from Wuhan, China, where describing the early experiences there, descriptive work from New York City, for example, looking at medication utilization there, manuscripts that are talking about expanded roles for pharmacists. I think of one where at the University of Iowa, they have placed the pharmacist on a rapid sequence intubation team that they're using to manage all intubations at that institution. So we're really seeing a variety of manuscripts. And as an editor, one set that I'm very interested in, we've seen some of these, but I think I'd like to see more. I would like to see reflections on individuals' personal experiences. I'm going to put my colleague Arash on the spot here and say that, you know, to see a reflection at some point from a pharmacy executive who has had to lead through this really at the eye of the storm would be very important, because we want to share information now in real time as much as possible to inform the ongoing response, but also in retrospect, we want to support lessons learned and also give an opportunity. This is probably one of the most profound experiences of all of our lives. We will probably never, hopefully, never live through anything like this again, and it's important. I was talking to a pharmacy executive from New York City the other day who mentioned that their institution has engaged a historian, and I'm very interested in doing that from an AJHP perspective, getting someone who can write the history of pharmacy's response to this pandemic, because it's something that we really do need to commit to the literature so that future generations can also understand what this really looked like.
Absolutely, and I think you've said it, Dan. It is the biggest thing we're living through, and hopefully we don't go through this again. But we do need to be prepared. And I think learning from history, learning from lessons, capturing some of these stories, especially from Arash, from pharmacists on the ground, I think is extremely important. And Arash, I think you have the transcript from today to help you with that.
Thanks.
I have my final question to both of you is we have pharmacy colleagues, health colleagues listening all over the world. They're listening live, but also tuning in later. What message would you like to convey to your colleagues around the world? Arash?
Yeah, thank you for this opportunity. I think pharmacists sometimes may feel a bit tertiary to doctors and nurses, as they are generally the heroes on the background, behind the scenes, if you will. And with each emergency disaster, we also were in the middle of Hurricane Sandy, for some of you that may remember that, and pandemic. We as a profession have the chance to step up, get ourselves inside those uncomfortable and unfamiliar situations to really showcase our value and our contributions to the world. Earlier, I mentioned the role of pharmacy, specifically with COVID, where there were no clear drug regimens, and nearly every patient had other underlying conditions. And really, without the pharmacist evaluation and advice to the medical teams, I doubt they would have been able to provide optimal overall care, and certainly optimal pharmaceutical care. Thank you.
Thank you for that. Arash. Daniel, what would you like to convey?
And I would start with what Arash just said. I would start with thank you. I would want to thank my colleagues on the front lines here in the United States, but around the world. I, as a pharmacist, don't practice on the front lines any longer, but you have once again made me so proud of my profession as I watch what you are doing to respond, and how important the pharmacists, pharmacy technicians, pharmacy residents, how important engagement has been. I think that we've learned once again through this pandemic, demonstrated the value, the essential role actually of pharmacists in ensuring safe and effective medication use in a very nimble way here. And I think the last comment that I would make, I would implore you actually to engage with your professional societies. I've tried to make the point today that ASHP as an organization couldn't possibly have mounted an effective response without the engagement of our members and understanding what our members need. So I would just encourage you to engage with your professional societies so that they can do the very best job to support you as you provide the very best possible care for your patients. And again, thank you so much for what you're doing.
Thank you so much, Dan and Arash. And with these powerful messages, we will wrap up today's episode. I would really want to sincerely thank you both for being with us today, and thank all of our viewers and listeners who will listen to us hopefully afterwards. I just want to remind everyone that this episode has been recorded, and the recording is freely available on www.fip.org/coronavirus, and that is the address of a webpage that includes all of FIP's COVID-19 resources as well. This is another opportunity for me to invite everybody to join our Facebook group, COVID-19 and Pharmacy, where you can join a global network of pharmacy discussing the pandemic. Finally, for any ideas or suggestions for topics or features with regards to FIP COVID-19 online program, Responding to the Pandemic Together, please do email me at lena@fip.org. Thank you once more, and stay safe, everyone. Thank you, Daniel, Arash. Thank you.
Thank you, Lena. Thanks, Arash.